Good evening, all the candidates present here. Today we have a session. It's actually a GI debriefing session, which will be taken by Dr. Asif Iqbal, sir, who is a HOD of Respiratory Critical Care and ECMO Services at Apollo Multispeciality Hospital, Kolkata. Also, if any aspirants have any queries regarding the registration of EDIC examination, you can ask at the end of the session. Thank you, sir. You may continue.
Yeah. Okay. So, student, 54-year-old lady want a history of severe gastric pain brought to the emergency department to evaluate thoroughly. Her past medical history is significantly for long-standing type 2 diabetes, hypertension, dyslipidemia, and she is on multiple medication. On examinations, is pyrexia, temperature 100.4 degree Fahrenheit. Her heart rate is 110 per minute, blood pressure 110 by 55, respiratory rate 28, oxygen saturation 98% on room air. Routine abdominal ultrasonography scan reveal gallbladder stone combined with bile duct diameter 8 mm, evidence of intraductal stone. Laboratory investigations showing that total count is high 18,000, hematocrit is high side 42, blood platelet count is 4,90,000, serum lipase is 8,000, serum calcium is 65, 6.5 milligram per dl, serum potassium 4.1, and serum blood urea nitrogen 65, creatinine is 2.5 per dl, and AST ALT is marginally high, alkaline phosphate is also high, serum bilirubin is 4.4, lactate is 3.2. She is admitted in the intensive care unit with suspected gallstone pancreatitis after 10 hours of treatment in the ICU. In spite of IV fluid resuscitation, IV broad spectrum antibiotic, her condition remarkably deteriorate with worsening pain, increased lactate from 3.2 to 4.4, and she's also developed hypotension. Which one of the following most pertinent next step of management for her condition? So you have an option continuous conservative management because the pancreatitis could worsen with endoscopic retrograde cholangiopancreatography ERCP, or consult surgery for the placement of the percutaneous transhepatic cholangiography tube, or consult nephrology for dialysis because her worsening clinical condition, consult gastroenterology team for urgent ERCP, and give IV fluid, which and switch antibiotic from piperacillin tazobactam to meropenem. So, for newcomers, in EDIC exam, there is a EDIC part 1 exam is a MCQ, but it has a two type MCQ. One is the K type question, while other is the A type question. A type question means the single best answer, and K type question means the true false. So you have to answer the every point whether true or false. Usually in the K-type question, the question stem is very shorter in a one-liner or maximum five-liner. But in A-type question, you might have a very long stem of the question. and you have to choose one of the option. So where is the problem? It is a gallstone pancreatitis case, and where the you have to tell about the what is the appropriate management single base answer. So you have an option. There are five options. So you have to choose the single base answer. Anyone? Yeah, you can give your answer in the chat box. So put your answer first, then we'll go for discussion. So anyone has given any answer? Yeah, let's see. So E. Give more IV fluid and switch antibiotic from piperacillin tazobactam. Mm. So here problem is the gallstone pancreatitis. So gallstone pancreatitis is something is that you have to clear the obstruction first because the bilirubin is getting high and patient is getting worsened. So first thing is the source control because sometime it is this due to obstruction causes the cholangitis, and so for the answer will be consult gastroenterology team for urgent endoscopic retrograde pancreatography. ERCP is the answer. Why? Because this lady gallstone pancreatitis associated with cholangitis and rapid deterioration because the total count is high and bilirubin is getting worse, and also the renal failure obviously is going worsening. But the main thing is that patient in a cholangitis, so you have to cure the obstruction fast. Then and switching antibiotic, we should provide adequate coverage less than 24-hour initiation. Not obtaining source control will not improve the condition. So only switching the antibiotic will not suffice. So, regarding the gallstone pancreatitis, the supportive care is fluid management, fluid resuscitation, early goal-directed therapy, or you can keep the MAP more than 75. So first, you consider as a when as you are dealing with a sepsis patient, so you first do fluid resuscitation and inotropic if require start inotropic support to maintain MAP, and always your approach should be ABC, airway, breathing, circulation, and oxygenation. You have to maintain the saturation more than 94%. And remember, in any sort of pancreatitis, early enteral feeding is recommended, either NG or NJ feeding, and avoid parenteral nutrition unless the enteral route is not tolerating. Then, okay. Then risk stratification for any pancreatitis. There are three scoring system you have to remember. One is the revised Atlanta classification, biceps, and the Apache 2. And if the persistent organ failure more than 48 hour in a severe, then it is a severe pancreatitis. Mortality is high. Role of antibiotic in pancreatitis not routinely required, but when there is a cholangitis or infective pancreatic necrosis, you have to give broad spectrum coverage. Like in this case, you have to give broad spectrum coverage. Piperacillin tazobactam was appropriate antibiotic. And ERCP indication for ERCP, acute cholangitis, yes, it is major indication. Persistent biliary obstruction suggested by rising bilirubin, dilated CVD, stone visualization, imaging, and worsening LFT. It is these are the indication for early ERCP, not indication of ERCP if it is a mild pancreatitis with spontaneous stones passage or improved LFT, no cholangitis. So if there is a no cholangitis, LFT is okay, mild pancreatitis, you can wait for ERCP. And definitive management is cholecystectomy and ERCP followed by cholecystectomy. Moderate to severe pancreatitis case, you can delay cholecystectomy 6 to 8 weeks. Consider interval ERCP with sphincterotomy if surgery must be delayed. Management complication like pancreatic necrosis, pancreatic collection, and organ failure. This all about the management of the gallstone related pancreatitis.